Hello, good afternoon, everybody. My name is Daiga Heisters. I'm the interim head of the Parkinson's Academy, and I am delighted to have you all along here for what will promise to be a very, very interesting talk this Friday on diet and Parkinson's disease. Let me introduce you to the two esteemed speakers for this afternoon. We have Professor Bas Bloem, who actually needs no introduction to the Parkinson's community. Probably one of the most recognisable individuals within the world Parkinson's community, and we're delighted to have him here, as we are Richelle Flanagan, a dietitian who's run a successful nutrition consultancy for the past 15 years. Richelle lives with Parkinson's and is a founding member of the PD Avengers, the global alliance of advocates united to end Parkinson's. And strangely enough, we're very influenced by a particular book that, yes, has Bas Bloem as one of the writers in it. So fantastic stuff. So just a little bit of housekeeping. Please use the Q&A function to ask your questions during the session. And at the end of Richelle and Bas speaking, we will dedicate time to that Q&A. And just a reminder that we have another masterclass for people who are interested in learning even more in depth around Parkinson's. And we also have our conference coming up. Both can be done virtually from your home or your office. So keep an eye out on parkinsonsacademy.co/courses. But with no further ado, I will hand you over to Richelle to start the proceedings. Richelle.
Good afternoon, everyone. Really pleased to be invited to speak on diet and PD by Daiga, and to be speaking alongside Bas Bloem. So I'm just going to kick off in terms of, I suppose, let me just see here now. There is the slide. There we go. So just to kind of give a bit of background to myself, I'm a dietitian now for 15 years. I actually retrained as a mature student in the University of Ulster in Coleraine in Ireland. And I was diagnosed with celiac disease. Actually, it was my first chronic disease when I was 42. And then at the age of 47, when I was pregnant with my second child, I was I pretty much picked up my own diagnosis of Parkinson's through micrographia. As a dietitian writing in my record cards, I noticed my handwriting was a lot smaller than usual. I couldn't make it bigger, so that was the giveaway sign for me. So basically, my diagnosis sort of led me as a obviously qualified dietitian and health professional to research, and I ended up going to the World Parkinson's Congress in Kyoto in 2019, and that was really where I really realized the impact of diet was probably maybe missing a little bit out of the picture. But the research that was presented in Kyoto just blew my mind. That's where I first came across Bas and Michael Oken in the Health Professional Study Day of the World Parkinson's Congress. And just, yeah, really made me realize how much we have to do in Ireland to improve access for care in general for people with Parkinson's, but from health professionals, but particularly in relation to diet. I was the past president of my professional body in Ireland, the Irish Nutrition and Dietary Institute, so I was used to advocating on behalf of people with chronic disease, and obviously now I'm one that has two conditions. And that I suppose really from Kyoto that led me to join the PD Avengers, which, as Daiga mentioned, is a worldwide global initiative that's only just launched about a couple of months. We've 500 people signed up already to basically really amplify the voice of people with Parkinson's in terms of the consistency of care that's needed across the world. So that's just going to give a bit of background to myself. So I suppose, just as I said on Twitter when I was saying I was taking part of this, I think diet is a serious missing piece of the puzzle for the management of people with Parkinson's. And I suppose the reason I have this is, well, how long is a piece of string? I was given 20 minutes to talk, and in terms of what to cover, it was difficult to think about what, because there are so many aspects that I feel in terms of diet. So I'm going to cover here in terms of topics that I felt were probably the most pertinent. There's actually a picture of me and some of my colleagues from Young Parkinson's Ireland that were in Kyoto, very appropriately with our bibs. But gut function, vitamin D, obviously considering the current COVID climate, protein and eating, I'm going to explain that. So I sort of was focusing from a COVID point of view at the moment, what's probably of key concerns. And so one thing I want to sort of talk about just very quickly is the picture of a person with Parkinson's. You know, I'm 51, I'm, you know, relatively fit and healthy. And when I went to see my neurologist, he was sort of like, you know, I don't think there's anything wrong with you, you know, let's check everything else first. And eventually had a DAT scan, which I couldn't have until my baby was born and breastfed. But anyway, it confirmed it. So in terms of image would be on the 1886 image, but they've updated it thanks to Michael Oaken and his colleague, Miss Armstrong, who's the lead author. So it is great to see a different view of, you know, Parkinson's affecting any gender, you know, race, age, it's across the way. I'm going to actually introduce you to one of the PD Avengers who was diagnosed at the age of 7. So I suppose it's just to show that obviously they're the motor symptoms, but I think this also, just want to give a shout out to another PD Avenger, Johnny Aikenson, who is a medic with Parkinson's. He's worked in A&E for many years, and basically just to highlight that it's not just motor issues that affect people with Parkinson's, but actually it's the non-motor images. And I think this image that he has drawn, he's a prolific artist, and I don't know if any of you know, but Parkinson's can lead you actually be pretty creative. So it's definitely opened Johnny's creative chest. So you can see there's many different non-motor symptoms, which many health professionals I think aren't aware of. And I have to say, as a person with Parkinson's, I find it so frustrating in my journey to be dismissed when I mentioned that I had swallow problems, when I mentioned I had hip problems, when I mentioned I had, you feel like a hypochondriac. And I spent a fortune going from Billy's Jack and then realizing, well, actually it is to do with Parkinson's. So, so I suppose the first thing, without further ado, is to go on to gut function. Is obviously a really key thing. I have a lot of interest in it because I have celiac as well. So that sort of interests me. My own theory is that my celiac disease is somehow connected with it. Not saying that it caused it, but I think in terms of the inflammatory process, it's interesting that things like inflammatory bowel disease have been associated. And there is a big study that shows that celiac disease, along with inflammatory bowel disease, the genetic locus is shared with Parkinson's disease. So I'm actually going to just steal a few slides that I took shots of when I was in Kyoto. And I don't think ParC Borgermer, who hopefully won't mind me using them, and from his presentation. But basically it's just to highlight that in terms of constipation is a big issue for people. And we know that constipation is a prodromal symptom. For many people with Parkinson's will complain that they had bowel issues, and particularly constipation, for many years before. But the only thing is, before they were diagnosed, the only thing is that often constipation is underreported. So I'm just going to get my picture out of the way here. I can see the screen here myself. So basically, in terms of prevalence of constipation, and said that up to 50% of people with Parkinson's can have the median rate have constipation, and up to 70% of people. The problem is that often the subjective view of whether you have constipation or not is limited in terms of the typical tools that you'd use, like the Rome questionnaire, in terms of constipation, that a person with Parkinson's might answer questions to in terms of whether they have constipation or not. So this study was basically showing how basically if you were to look at the so in terms of subjective constipation, when people are asked with the Rome 3 survey, 33% of people with Parkinson's said they had constipation. But when an objective study was done where they actually scanned the bowel and the colonic transit, 79% actually had constipation. So there's quite a big difference between people understanding that they have constipation. What they think is normal is probably not normal. So I suppose in terms of the other thing about the constipation was quite important is that in a study there recently, well, it's 2016, an author called Rachelle, it showed that basically a lot of people with Parkinson's are taking quite a bit of fiber, but because they're aware of their constipation. But one of the big problems is the type of fiber they're maybe taking. So in terms of quantity, that another paper recently in just a study that was done in Belgium just this year by Bert et al. Basically showed that it was about 28 grams of fiber a day, and this is particularly insoluble fiber, which is kind of like the roughage. It's the whole grain part of the fiber. Basically was associated with a better levodopa availability. So obviously if you're constipated, it means that one of the key drugs for helping Parkinson's symptoms is not absorbed as well. So this is a really key thing that has to be sorted for many people with Parkinson's, which is not being addressed. So in terms of also with constipation, it's important that you have a mix of soluble and insoluble. So the soluble is kind of like the fruit and veg, which kind of, you know, creates the sort of softness of the stool, and then the insoluble fiber is kind of the whole grain, the roughage, like nature's broom, as we call it, to help to move the bowels. So you need a combination of both of these to keep a gut healthy, and that's for the general population, but even more important for people with Parkinson's. And in fact, in the Rachelle study, although they said in their study of eating habits of people with Parkinson's, it said that although, and also the more recent study, that all people with Parkinson's were getting in maybe 25, 27 grams of fiber a day, they weren't getting enough fluid in. So if you can imagine, you know, like anybody, you put lots of fiber in, it's going to bung you up if you don't take plenty of fluid. And we do know with people with Parkinson's that they don't actually tend to drink enough fluid. And the two studies I mentioned actually show that the people underdrink when they have Parkinson's. And the question in that is whether it is that basically they lose the autonomic sort of function to remind you that you're thirsty, that they don't drink enough, is one of the questions. And also in terms of, it was actually a nurse that mentioned it, actually on a lady called Jane Price mentioned it about, you know, levodopa can itself cause sort of dehydration in terms of people not taking enough fluids to counteract that, and that can affect blood pressure as well. So there's a number of reasons why fluid is really important. And then also in terms of laxatives, so I'm going to come on to that as well. So in terms of fiber, it's really important in terms of the guidelines generally for the general population. It would be the same for a person with Parkinson's, would be 25 to 30 grams of fiber a day is really important, but to have a mixture of both, because if it's all just insoluble, then it's going to be, you know, get a bit stuck. You need to have that sort of soft fiber. So just, you know, in terms of fiber, it's basically, as you can see here, the difference is the color. So if you know, one's plate is very white, you're not getting enough whole grains, you're not getting enough fiber in your diet. There's a whole range of different whole grains that you can have out there, and some are better nutritional quality than others. So rather than just having, you know, whole grain pasta, it's mix it up with other types of grains that have other sort of, you know, are protein rich, have vitamin B12 in it, other B vitamins, really important, and especially for the likes of myself who would be celiac. Obviously there's certain of these grains that are not appropriate for people with celiac disease, but things like quinoa would be good, you know, for example. So just in terms, again, talking about soluble fiber, so it's all the fruit and veg, and also in terms of soluble fiber, it's things like your lentils are really important in terms of solid, and porridge oats as well. So in terms of the fluid, I mentioned there, it's really important. So in terms of fluid, obviously the quantity, so generally what we sort of say is about 35 mils of fluid per kilogram of a person's weight for anyone who is under 65, and anyone who's over 65, it would be about 30 mils of fluid per kilo of weight. So you could work out in terms of, because obviously people with Parkinson's have different ranges of body weight, so you need to be more specific and targeted around it. The general kind of is, you know, 1.5 to 2 liters a day, but if you've got a large gentleman who is young onset Parkinson's, doing a lot of exercise, his requirement is going to be a lot more than someone who's maybe 80 who is you know, smaller. So just to keep that in mind. Obviously in terms of fluid, I wanted to put this in because it's kind of a bit of a bugbear of mine with regard to caffeine. Often I've heard in terms of, you know, people with Parkinson's, oh, don't take caffeine because it's going to dehydrate you. So the research would show that if you're taking a moderate amount of caffeine, so that's 300 milligrams a day. Now that is 1 cup of, you know, strong coffee in the day, or 3 cups of instant coffee in the day. But it's a great way for people to get some fluid in, because it's majority water. And the other thing is we can't, you know, disregard the fact that caffeine can help increase alertness and enhance performance. We know with people with Parkinson's, fatigue is a problem, apathy is a problem, etc. Energy is a problem. And also, obviously, we can't discount that there is some very interesting research with regard to caffeine intake in terms of Parkinson's links, etc. So there's a lot of information out there, I think, that, you know, is putting people off caffeine with Parkinson's. I don't know if that's entirely appropriate. Obviously, on the flip side, if you kind of whack in way too much caffeine, this is what it does to anybody out there who drinks too much caffeine. And obviously for us with Parkinson's, you know, release of cortisol, the stress hormone, adrenaline, is not good for us. So, and if you've got, you know, problems with your blood pressure, orthostatic or otherwise, high blood pressure, it's, you know, not a good thing either. And also in terms of gastric ulcers, we don't want to set those off. So, and I suppose the other thing as well, in terms of caffeine, for people who are having problems sleeping, it remains in the bloodstream for up to 8 hours. So basically people should avoid it for at least 4 hours before bedtime. And there are specific people who have more problems with this than others. So, and the other thing just to remember is that tea is the gateway to biscuits and coffee is. So a lot of people talk about putting on weight with Parkinson's. The other thing in terms of fluid, is this something that we'd use as dietitians on a regular basis to actually ask people to look at the color of their pee to know whether they're dehydrated or not. So if you're well hydrated, your urine should be pale colored, straw kind of colored and plentiful. It's a good indication that you're more well hydrated. If it's dark, you're looking at, you know, for people, and again, you know, alcohol is the one that one should be careful about in terms of dehydration. So just in terms of the other thing I just wanted to draw attention to, this was a really fantastic study I came across by Fasano et al. In 2015. And basically it shows here the different areas that can be affected by people with Parkinson's in regards to the gut and the gastrointestinal tract. So things like Helicobacter pylori has been associated with interfering with levodopa absorption. So has small intestinal bowel overgrowth. Both of these are kind of in this sort of 20 to 25% of the population, maybe even higher in Helicobacter pylori, can affect people with Parkinson's. And so what I would say is, if their symptoms are worse, is really they need to have a look at the basics first before we start adding in other medications. Are we actually improving what they're taking is working for them to its optimal amount? Dysphagia, I'm going to come on to later, obviously is affected. Gastroparesis, where the gut basically stops working in terms of the gut sort of slows down, and it's obviously a very serious issue. And then the constipation I've mentioned there. But it does mention under constipation about laxative use. I'm just going to mention a study that I went over to take part in King's College London with Sylvia Dobbs' team. Amazing studies that are going on there, but she happened to mention this study to me, and I looked it up, and it was about looking at rigidity in Parkinson's disease patients. And in this study, it actually it said that regardless of laxative use, that people with Parkinson's basically, I think it was every 2 years, the rigidity increases by 5%. But their study showed that actually using prophylactically laxatives actually helps to reduce rigidity in people with Parkinson's, which ties into my mind with the whole issue around the constipation. But in summary, in terms of her paper, it was really sort of saying that there's something else going on there, and it's potentially to do with the dysbiosis and the microbiome, rather than just necessarily improving the constipation. Because as we know, with constipation, that can then obviously affect things like gut bacteria in the bowel. So I just wanted to kind of highlight this saying in the paper, which I thought was very good. Like other chronic diseases, Parkinson's is likely to be a multi-step, multifactorial, but this does not preclude a systemic explanation and interim clinical solutions. Targeting environmental influence has potential for cost-effective screening, prophylaxis, and amelioration. Indeed, the misfolded protein theory of PD pathogenesis need not relegate any environmental theory to being a hit and run and remote in time. So I think that's really, spoke to me about how Parkinson's, the diet we're missing a trick by really improving that at the baseline to see how much we can improve people's quality of life. So that's in terms of that side of things, in terms of gut function. The other thing is vitamin D. I really felt it was important to highlight this in the COVID climate at the moment. Obviously, there is very much building evidence to show that it has benefits potentially in terms of reducing the risk of hospitalization, but more importantly, ICU. And the big evidence is around people who are deficient, more so in terms of, the impact, but obviously in terms of, even sort of low levels may have it. And the way I look at it is it's beneficial. It's not going to do any harm to reach the general kind of guidelines. The evidence would show that people with Parkinson's in the studies actually, in those two studies I mentioned early on, both showed that people with Parkinson's did not reach the 15 micrograms a day, which is kind of a general rule of thumb. Often 10 to 15 micrograms a day were under that. And also blood levels were showing that they were deficient or insufficient. So obviously that has big implications. Not obviously from vitamin D, bone health is a real issue in terms of people with Parkinson's, because we know we have a higher risk of falls. And the research studies would show that people with Parkinson's are low in vitamin D anyway, and it's not necessarily to do with, you know, being housebound, etc. It is shown in younger people as well. So I don't know what's going on there in terms of the mechanisms, but something is. So bone health, obviously, we want to protect our bones. And then the other thing is there has been studies to show that there may be a neuroprotective effect of vitamin D in the sort of in the inflammatory sort of process and in the redox system. So vitamin D is really important. So in terms of, oh, I think my vitamin D slide is mixed up there. I'll show you the amounts later on. So in terms of then I wanted to come to was in terms of protein, really important about protein is levodopa and protein. So really interesting in the research done by Bert in Belgium there in a cohort of people with Parkinson's. It said that 2/3 of people who were aware of their you know, Parkinson's and the link between protein and levodopa reactions and interactions. So basically just to explain that protein foods basically interfere with the absorption of levodopa both at the gut level and also at the blood-brain barrier. So it's advisable that people with Parkinson's take the levodopa half an hour before they have a meal with protein in it, or an hour afterwards. It's longer afterwards because obviously the protein has to have time to digest through. But in this study, it showed that 2/3 of people with Parkinson's were aware of this interaction, but less than 20% of people with Parkinson's took their levodopa according to that advice. So 2/3 were aware of it, but less than 20% were actually doing it. So there is a thing called the protein redistribution diet, the PRD diet, that has been shown to have benefits in terms of improving levodopa effect in people. And basically what it sort of advises is that people would actually distribute their protein so that it's at the sort of latter end of the day where maybe they're not as active, so that they can actually go about their day and have less symptoms during the day. So that is there's quite a bit of evidence around that, but people aren't following it, and it's not probably been used in practice enough. And obviously it needs to be used alongside, you know, food diaries and that to be able to assess that it's actually working. But the study by Rachelle showed that protein intake by 10 grams over the needs of a person, which is 0.8 to 1 gram of protein per kilogram body weight, led to an increase in levodopa dosage. So, you know, if people are having too much, it was interfering, and it meant that they had to have more levodopa. And obviously we know with levodopa increase, there are other issues there. What I would say about the protein redistribution diet, people often think it's going to affect body composition, and it can. So it needs to be done in correlation with the dietitian, a properly qualified dietitian, to make sure that it's done correctly so that they don't lose body weight, because we want to make sure people with Parkinson's do not lose muscle. Protein is really important for muscle. And obviously from bone health, protein is really important for bone health as well, and also delivers a lot of vitamin and minerals. And interesting enough, quite a few of the studies show that people with Parkinson's are low, in particular in iron. So I just want to show you here in terms of eating. This is a good friend of mine and PD Avenger, Matt Eagles. And just to sort of share with you some of the difficulties a person with Parkinson's might have with regards to eating their meal. So you can see here Matt is suffering from dyskinesias, in fact, but he is determined to eat that plate. But in terms of, you can see the issues that it can have for people with Parkinson's. So that is just to kind of say to you with regard to, you know, there's issues we need to take in with regard to timing of meds, so people can actually eat their meals without maybe a tremor, without dyskinesias, or to try and reduce that as much as we obviously physically can. Possibly can. The other section I just wanted to talk about was eating, in terms of, you know, just going on from Matt's video there, that there are challenges. But one of the key things is the swallow function. And again, I'm just stealing a couple of slides from a speech and language therapist, Japanese speech and language therapist in Kyoto. showing that dysphagia happens in 50 to 90% of patients. And the research I've done myself shows that, that maybe only 5 or 6% of people with Parkinson's actually report a problem with their swallow. A lot of them aren't aware of it. And it presents early in the state of illness and not related to functional severity. And this is actually what happened to myself. I felt that I had an issue, and I had to push and push, eventually got a video fluoroscopy. As a result of this talk, I went home and demanded one. Felt as if I was probably being overly made feel as if I was being, I'm young and I shouldn't have any problems. And quote unquote, I was told I have the swallow of someone who's over 65. So there are issues, and they have to be, dealt with, because a bit like anything else, there's no point in waiting until it's a problem, and dysphagia is much worse. So the other thing is, obviously medications can affect dysphagia. Things like, as I say, it can make issues in terms of dehydration, obviously in terms of wearing off, risk aspiration, and also things like swallowing, etc. There are multiple disorders basically associated with Parkinson's with regards. So there's a raft there that you can see in terms of drooling, reflux, residue in the pharynx, very many different things that are going on. I think this is quite a startling slide here as well, that basically and I think this is what really made me sit up. One of the biggest killers of people with Parkinson's is dysphagia as a result of pneumonia, and also because of nutritional related issues, obviously in relation to dysphagia. So as a result, I'm just going to wrap up in terms of, as a result of the Kyoto conference, the WPC conference, I decided that I was going to make my mission to share my experience with regard to my own journey and what I've learned with my colleagues in Ireland. So I wrote an article for our professional body magazine. If anyone is interested, I can share that on to them. I have an awful lot more areas that are covered in that. And it just shows you here, this is from a paper by Komar et al., showing all of the non-motor. And really, as a dietitian, we have so many areas. So what I would say is, from cradle to grave of Parkinson's, from early stage to late stage, dietary input is really, really important. So I just want to acknowledge the people who are in the slides, and also Johnny, Matt, Fiona Lithander, who helped me write the article, and Professor Claire Corish, who's a professor in nutrition and dietetics here in Dublin. So thanks very much. It's a bit of a whistle-stop tour. So I'll pass over to Bas. I think he's going to take over, so I'll stop sharing.
Well, thank you, Richelle. That was an excellent overview. The fun fact for you guys at home to know is that we independently prepared a PowerPoint presentation, unbeknownst that the other person was doing the same thing. I think you've covered all areas that are relevant. I will skip my slides because I think it's important that we engage in a lively debate with the many followers. We're closing in 100, which is wonderful. I'll start with the first one here. Aisling Daly says, my father has Parkinson's, and the main dietary recommendation he got from the GP was to increase eggs and beans to improve dopamine levels. And the question is, can diet or specific foods increase dopamine levels? I'll leave it to you to answer first, Richelle, and then I'll follow up on whatever I might add to what you're saying. And you're muted.
Yeah, I think in terms of natural forms of dopamine, in terms of foods, the quantity, would have to be very high to reach the same level. Certainly that's what I've seen from my research anyway. But I don't think that it would have the same effect as having the, the medication itself, if one is necessitating having the levodopa. I suppose one of the issues in terms of, just to go back to just see what she says there, eggs and beans, I suppose the counter argument there is just with relation to is this person on, they aren't on any Parkinson's meds at the moment. Obviously, if they were on Parkinson's meds, then you have the issue of the competing protein with the dopamine medication, but maybe he's not on medications at the moment. So, I mean, I would sort of say that really it needs to be reviewed by the neurologist in terms of what's going on in terms of their symptoms, and depending on sort of multidisciplinary approach, then the dietitian could sort of get involved with regard to the diet side of it.
Let me chime in here. I think the straight answer is there's no evidence for this, period. I think don't do this. There's no evidence that your dopamine production goes up if you eat more beans or eggs. If you're on levodopa medication, as Richelle was pointing out, you run into all sorts of problems with levodopa absorption. The one thing that I want to emphasize, it was in my PowerPoint, but this is a good moment to talk about it, is Mucuna pruriens. That is a food supplement that comes from an Ayurvedic bean that contains levodopa, which is exactly the same levodopa that is contained in Sinemet or other dopaminergic medications. People think that when they are not ready for real medication, that they can resort to mucuna. But this is a mistake because it's the exact same levodopa, except it is a probably unwise way of taking levodopa because we take levodopa combined with a decarboxylase inhibitor that's called either benserazide or carbidopa. Levodopa is metabolized into dopamine. Dopamine doesn't enter the brain well. So if you take mucuna pruriens as the only source of your levodopa, the majority of that levodopa will be converted to dopamine in your blood and never ever reach the brain. And I regularly see quite severely debilitated patients in my clinic who are clearly in need of medication, who refuse to take medication because they are afraid of medication. Take mucuna, but it's not a wise thing to do. Two things I want to say here is, if you insist on taking mucuna, which it is by itself an interesting compound because it may contain, the bean may contain other stuff that could potentially be helpful, but it's poorly researched, take it together with carbidopa. We have a published case report of a lady, severely debilitated, was only taking mucuna, and all I did was add a fraction of carbidopa, and she was 360% better. Videotaped, published it. So that is important advice to people. Mucuna is a medicine. It contains levodopa. And if you take it either with carbidopa or benserazide, or if you are already on levodopa carbidopa, then you've got your carbidopa embedded in your levodopa. And now that same carbidopa will help your mucuna, right? So most of my patients take a combination of levodopa, real stuff, with mucuna, perhaps as a supplement. But I think that is important. But that is the only naturally occurring resource of dopamine. So another question relates to discoloring of the urine when people take a COMT inhibitor. In particular, entacapone is notorious for that. Do you have any experience there, Richelle, or do you want me to cover that question?
Yeah, I mean, to be fair, that's it's something I wasn't aware of. So, you know, if you want to cover that, if obviously people are on specific things, like many medications can color. So obviously you need to take that into account when you're asking people to check their urine.
Sure. So yes, particularly with entacapone, the urine can turn orange, and people with urinary incontinence particularly dislike that because it colors their underwear. It's something you need to point out to people. Sometimes people think they now have a bladder infection, so it's a matter of instructing your patients. COMT inhibitors are partially useful because they extend the half-life of levodopa. In general, we're talking about diet here today. I think almost by definition, all patients have more or less constipation, and Richelle really nicely pointed that out. And my own preference is to avoid long-acting drugs in people with slow bowel movements and delayed gastric emptying, and to resort as much as possible to short-acting drugs, such as dispersible Medobar, which is my favorite drug in constipated patients. It works quicker, but not shorter, and the long-acting drugs I tend to avoid. So that's that question. Is there a question in the Q&A that you like to address, Richelle?
I'm just seeing here one here by Lynn. Protein sensitivity is very difficult to manage, and sometimes redistributing protein to the evening can still be difficult for patients. Sorry, this just jumped over there. Where can more information be obtained when they're maybe also swallowing differently and weight loss also apparent? Which supplements could help? So this is a really important thing because, as I mentioned, if you do a protein redistribution, it's very important that people still stick within at least the 0.8 gram per kilogram to 1 gram per kilogram sort of amount of protein in the day, and that's just how that's spread out. And in terms of if there's a swallowing issue, it's really important the speech and language therapist is brought in there, and there's a proper assessment of video fluoroscopy done to know exactly what the extent is, and a dietitian then. So they would work together, the speech and language therapist and the dietitian, in terms of modifying the consistency. So if there's swallowing different, they might need to thicken the diet, or make it a different, a moist diet, or might have to be a liquidized diet. But that's really directed by the speech and language therapist in terms of assessing that, and then the dietitian will help. And obviously, when diets are liquidized or different consistency, then it needs to be bolstered with extra supplements. So there would be supplement products, things like we would use here, Fortizip, Ensure, various different things that are probably different around the world, and adding extra sort of calories, things like collagen and things like that into the diet to help bolster up. Because a lot of people with Parkinson's, particularly with advancing Parkinson's, tend to have malnutrition or sarcopenic. So this is actually a really important question. And what I would say is, what I see is that people with Parkinson's are not getting that multidisciplinary care around diet advice between the speech and language and the dietitian. There just isn't access. I think that really needs to be addressed, would be what I'd say.
Yep. And just quickly, in addition, there's also a question by an anonymous attendee asking whether there are exercises to improve swallowing function. The interesting thing,
I saw that
and I
thought I'd show you this just in my own experience. So this is what I was told. So in terms of my own swallow, there was an issue with the sort of the early phase, the laryngeal swallow. And obviously in terms of the COVID climate at the moment, obviously we don't have a higher risk of catching COVID, but we are at risk when we got it and we're in hospital because of the breathing and the swallow issues. So this was something that was actually advised to me, was to use an expiratory muscle strength trainer. It only cost €40 for me to get it, and it basically helps to strengthen that area. But again, it really should be advised through a speech and language therapist to make sure you're training the right muscles, because not everybody has my issue. They might have a different issue lower down, or etc. So really a speech and language therapist needs to be involved if there's anything to do with your swallow.
And in that regard, it's important to emphasize that the difficulty swallowing is just like the difficulty walking. So everybody recognizes that a physiotherapist can increase stride length for gait that we can cover freezing with external cueing techniques such as rhythmic, auditory, or visual cues. The same techniques apply to swallowing, and an experienced, dedicated speech and language therapist who understands Parkinson's as a disease and who treats many patients can help improve the swallowing function. So that is important to say. Richelle, somebody says, what can we do to avoid weight loss when people exercise a lot? We recommend a lot of exercise, and I'm a great fan of that. Yeah. And yes, people may lose weight when they exercise. I have something to say, but you cover it first.
Yeah, well, again, I think, when you've got, I know I'm banging on about seeing a dietitian, but I think it's really important to look at the total picture, to have an understanding. And a dietitian would look at exactly what their work situation is, their exercise, what their timing of meals, are they married, do they have kids? Because I know as a person with Parkinson's, a lot going on in people's lives, they're trying to live with Parkinson's. So it's about, are they eating? I mean, if they're doing a lot of exercise, they should be eating potentially 6 times a day. And obviously then you need to take into account their meds and protein timing. You need to take into account if they're doing endurance, that they have to have enough carbohydrate. And, I fear in terms of, there's a lot of, myths out there in terms of carbs being bad, etc. So, this is often, I see this in people who don't have Parkinson's as well as Parkinson's. So it really needs a good review of their diet to make sure they're getting adequate calories and where to get them from, so that it allows them to get the best out of their lives, but doesn't interfere with their symptoms,
I just wanted to add that there's quite a body of research to show that people with Parkinson's are at risk of losing weight, that losing weight rapidly is a poor prognostic sign. It can signal the presence of atypical Parkinsonism. So it's the red flag, maybe alerting you to the fact that it could be a more aggressive form of Parkinsonism. But even if you have bona fide Parkinson's disease, rapid weight loss is a predictor of earlier onset of dementia, earlier admission to a nursing home, and earlier death. So whether mitigating weight loss avoids that risk is not known. That intervention study has not been done, but my interpretation is that we should really aggressively help and support people that have a lot of weight loss. And in addition, weight loss can signal malnutrition, deficiencies. And I know, Richelle, you've covered vitamin D, but I think all women over the age of 50 should have vitamin D supplements. And there are interesting anecdotes, not more than anecdotes, of people who took vitamin D supplements and their motor function improved. Be aware that any compound can be toxic, so it's good to have it measured, and don't take an overdose, because even vitamins can be toxic if you overdose. So that's that. Hans van Geluk, who is a fellow Dutchman and a wonderful guy, by the way, has a question which I think Richelle can address. Is it possible that you still remain constipated even though he has resorted to an Italian diet with lots of olive oil and rice and nuts, but he's still constipated? Although he says that Macrogol, a laxant, has helped him. Can you address that?
Yeah, well, I suppose in terms of my presentation, I mentioned there with regard to, I mean, I'm glad he mentioned about the Italian diet, because people often ask what is the best diet for people with Parkinson's, and certainly at the moment the Mediterranean diet is kind of winning out. Although there was a very interesting study there recently that showed that healthy eating can also just generally, I think that's where a lot of people with Parkinson's just aren't getting the basics right. So in terms of the Italian diet, definitely can help, but obviously plenty of, as I mentioned there, the fruit and vegetables in terms of soluble fiber, plenty of the whole grains. And I suppose in terms of Italy, you tend to see a lot of the white rather than the whole grain maybe versions of the fibers. And as I mentioned there, the study showed that people who took in 28 grams of insoluble, which is the roughage, the whole grain fibers, had the better response to their levodopa medication, because obviously they were less constipated. So I think that's one thing. And what was the other thing he was saying? Sorry, there.
Well, I think we've covered that. He said that a laxative has helped him. So that is good news.
The studies seem to really show that the laxative. Now, I'm not saying that you would, willy-nilly put people up with Parkinson's on laxatives, but I do think it's worthwhile. More research would be really interesting on it in terms of the whole link to rigidity and the microbiome.
Yeah, I'll take this next question, which is by an anonymous attendee, asking about the link to the microbiome, the bacteria in the gut, and their role in causing Parkinson's, and whether laxatives could be a solution. So that is, I think, one of the most exciting areas, I think, in Parkinson's. It is clear that there is a link between the gut and the brain. It is clear that the microbiome in people with Parkinson's is changed. It's different from healthy people, and that the nature of that microbiome might play a role in aggravating Parkinson's. Exactly which bacteria are doing this is not exactly known, and whether affecting or trying to change that microbiome, say using probiotics or using antibiotics or using laxatives, is also unknown. What we do know is that chronic constipation leads to bacterial overgrowth, and there are particularly bacterial species that create an enzyme called TDC, and TDC converts your levodopa into dopamine, so the dopamine leaves your body with your stools without ever entering your brain. So one reason, if not anything else, to treat your constipation is to try and avoid that bacterial overgrowth and that production of enzymes that will make your medication less effective. So I think dietitians, GPs, internists should really aggressively treat constipation. There's one study on probiotics, which was positive, but that requires confirmation. A probiotic could also change things for the worse. So don't think, oh, a probiotic, let's just try it for heck's sake. It could also have adverse effects, and it requires further study. One positive study in neurology, but that's it for now. Let's see. There's a question about a PEG catheter and indications. Is that something you could address, Richelle, or do you want me to cover that?
Well, I say I'm not working clinically in the hospital. I'm certainly aware, obviously, unfortunately, if someone's got to a PEG, it's usually in terms of obviously swallow issues there. So it needs obviously a dietitian to be involved in terms of what what formula they need, and you know, whether it's an interim thing or, you know, whether the PEG can be taken out or not. But I don't know what the specific kind of concern is with regard to the question.
So a PEG catheter there's two major indications, I think. One, of course, is in combination with levodopa carbidopa gel, which is one of the 3 advanced treatments. We have apomorphine pump therapies, we have deep brain stimulation and deep brain surgical lesion techniques, and we have intraduodenal levodopa gel. So that is delivered through a PEG catheter right into the duodenum. So that's one reason to use one. I think we are underutilizing PEG catheters in the latest stages of Parkinson's. As Richelle was pointing out, one of the major, if not the major cause of death is pneumonia following aspiration difficulties. A PEG catheter then serves 2 purposes. One, to mitigate the risk of pneumonia, but also to ascertain an adequate food intake while still being able to enjoy small pieces of food and still enjoy the flavor in the mouth. And I think having a PEG catheter in patients with severe dysphagia that's otherwise difficult to treat can be life-saving or at least life-extending, while people still allowing to enjoy the flavor of food. At the same time, and I'm going to say it out anyway, it's a tough call. Sometimes people call a pneumonia an old man's best friend. I'm not sure if you know that expression. And when people are severely debilitated and one is in the final end stages of Parkinson's, it's easy to put in a PEG catheter. It's very difficult to take it out. And I think it's a really tough decision. It takes time with the patient and the family to really decide, do I want this? Do I want to extend my life, which is maybe more quantity, but does it extend the quality of my life? And that is really an individualized, personalized decision. So what I'm saying is don't just blindly put in a PEG catheter, but discuss it with the family. Anything you want to reflect on that, Richelle?
Yeah, no, I just totally agree. As a dietitian, I would have worked in hospitals, and yeah, it's obviously in terms of the palliative side of care, people with Parkinson's, it's a really important, you know, discussion in terms of the end of life. It's something as dietitians that we have to be very mindful that sometimes there's a time not to push, you know, dietary therapy, and it's about quality of life towards the end. So I think it's a really important point.
Yeah, there's an interesting question to both of us. I think we've partially covered it, but not entirely. It's about the bacterial overgrowth and whether we should routinely test our patients for that. I can say that the more I read about Parkinson's and the more I read about the fascinating gut-brain axis, and the more I read about the importance of bacterial overgrowth, I'm beginning to realize that I'm underutilizing this myself in my own clinic. So I'm determined to do it more often. It's a breathing test where you can measure from the breath whether bacteria have changed in the wrong direction. People are working on a less invasive, maybe a blood test. And the second part of that question by the same attendee was, are there particular probiotics that we would recommend? And I would recommend not to take any probiotics until we have the evidence which one is best, because again, they can also have adverse effects. Richelle, do you want to chime in?
Yeah, I think SIBO should be tested for in, you know, certainly obviously with, you know, good assessment of the patient situation, the constipation, what's going on. But I think SIBO is something that's been under tested. I think that paper is really interesting that outlined what should be, and I think it should be tested for people with Parkinson's, should be tested for Helicobacter pylori, SIBO, those things should be looked at. So I would agree with you. I think in terms of probiotics, one of the speakers in Kyoto as well, you know, really blew my mind in terms of her research that she showed that it can be dangerous in some cases so in terms of Parkinson's patients, in her particular study showed that bifidobacteria and lactobacillus were raised in people with Parkinson's. So her question was, and people are buying lactobacillus and bifidobacteria supplements off the shelf left, right and center, and it actually may be not a good thing for people with Parkinson's to be doing that. So I do think it is buyer beware at the moment. In terms of probiotics, I would not be taking them. I'd actually be dealing with the underlying constipation, and I'd be asking for SIBO testing as well. I've actually done the testing myself, the breath test. It's you know, it's very easy to do, and has good sort of results in terms of accuracy. So I think that would be the thing I do. The other thing I would say, Bas, that I find quite concerning quite recently, there was a big study, I don't know if you saw it, a Helsinki study that linked the use of antibiotics with Parkinson's disease risk. And that's my only concern with regard to, say, if you find SIBO, is what are the effects, you know, that was in relation to Parkinson's risk. And I know there are some studies to show that antibiotics can help relieve some, you know, symptoms of Parkinson's when you maybe have the dysbiosis. But, you know, I'd be concerned. I actually was talking to someone, a gastroenterologist recently, sorry, and they mentioned about using antibiotic like a probiotic, so regularly. And I was like, okay, I don't know if that's such a good thing either. So I don't know, I know I'm throwing a bit of a curveball there, but any view on that?
No, I completely agree. And in fact, I'm going to answer another question in one go here, and that's by Camille Carroll, who is a wonderful physician in the United Kingdom. Camille, hi, wonderful to have you at the other end of the line. And Camille actually raises a very good question. And she says, Bas, even if you were to find bacterial overgrowth, how would that change your management? And of course, that is the right question to ask, because asking for a test is one thing, to let it change your management. And the honest answer is, Camille, and that's why I think your question is well taken. And that's maybe the reason why I've done it, haven't done it that much, is that I frankly wouldn't know what to do with the result other than to ask a GE specialist or a geriatrician who are much better at these issues than I am to say what to be done about it. I would probably aggressive anyway, which I was doing anyway. So maybe that's just the safest answer. So good question, and probably more work is needed. Another question that I quickly wanted to ask is by Iram Yakiskli. I apologize sincerely if I mispronounce your beautiful name, who is a dietitian and asks for procedures and what support for dietitians. And I can tell you that we developed a guideline for dietitians in the Netherlands that was translated in English. And I can share, it's all available for free, and I can share it with Daiga so that it can be disseminated through the Parkinson Academy. So that answers that question. And another interesting question, which I can briefly allude to and then hand the microphone to Richelle, is by Nirav Parekh about end-of-life issues and advanced decision-making is an important part of palliative care. And should the advice come from a dietitian or from a multidisciplinary team? And the two things I want to say first before handing the microphone to Richelle is A, I think fortunately we've come now in an era where we realize that palliative care and advanced care planning is not restricted to oncology, that people with Parkinson's deserve advanced care planning and palliative care support as much as people with oncology. In oncology, it's clear. You aim for the cure with chemotherapy or surgery. And once that moment arrives when chemo is no longer effective, bang, you enter the palliative phase. There's a clear-cut moment in time. For Parkinson's, it's unclear. And I think the consensus that is beginning to grow is that we should start advanced care planning at the onset of the diagnosis. And that palliative care is something that extends throughout the course of the disease. And I completely concur with Nirav's question. I think this is a multidisciplinary team issue. And depending on the issue at stake, it could be the dietitian initiating the debate, it could be the Parkinson nurse, it could be the geriatrician. But I think we should all be aware as a multidisciplinary team that advanced care planning is critical throughout the course of the disease. It starts at disease onset. Richelle?
Yeah, I mean, this actually came up at the World Parkinson's Congress in Kyoto, and I have to say, you know, obviously with someone with Parkinson's, you know, like, oh, do I really want to think about that now? But actually, when it was presented, it made sense because, unfortunately, when you're given a diagnosis, no one can tell you how it's going to progress. So, you know, in a way, it's just kind of, you know, getting a bit of things in order in terms of just having a sense of where things might go. It doesn't mean it's going to go that way, but I think it's no harm because also it affects, as we say, you know, people often talk about care partners of people with Parkinson's, but we actually don't like that term because we say everyone who's in a family is living with Parkinson's. not just the person with Parkinson's. So actually that advanced care planning is really important for everybody in the family. So I think to take a more holistic approach to it and a more positive maybe approach, that it's not a negative, but you know, just good housekeeping. Obviously in terms of the palliative, when it really comes to that, I think that, you know, it is important in terms of knowing what you might like, and say in terms of things like peg feeding, whether you don't want to be peg fed, you know, that is something that maybe you have a right as a patient to sort of say early on. And I think in terms of the dietitian being the person who leads that, I would say no. I think the dietitian, as you say, might be the first person that has the discussion, because it is around their eating, and you know, it's such a personal and cultural thing, eating. So it might be flagged by the dietitian, but I think it's very much the MGT approach in terms of that end stage.
Yeah, I completely agree. And a final question also for you, I think, Richelle, because I don't know exactly what to answer. And please be a bit concise, because I want to be mindful of people's times, and we have 2 minutes left. Are there any foods that help to reduce or avoid the delayed gastric emptying? What is the dietary advice if you have delayed gastric emptying?
So in terms of the delayed gastric emptying, I suppose this comes down to as well the sort of constipation. You know, if you're overloading the bowel, and this is where you get gastroparesis, where the bowel will, you know, obstruct. So I think if there's any indication of that, you need to be getting in to see your team about it. You need to be involving a gastroenterologist, and specifically, you know, a dietitian who's probably experienced in that area. But that would be my concern if they're asking that question. You know, I think it's probably beyond this in terms of need to know more information in terms of what that person is, you know, why, and you know, obviously there's certain foods that can help gastric quicken it. So, you know, higher fat foods can actually sometimes quick, but sometimes can take longer to digest. So that can be a problem as well. So I think there probably needs a bit more information before I get to answer that specifically.
Okay, I can add quickly in the dying seconds that medication can sometimes be helpful. Domperidone or cisapride can help to improve gastric emptying. If you take domperidone, you need an ECG to check for prolonged QT intervals, because that could kill you. It's rare, but it needs to be checked. So medication can sometimes be helpful as well. I see lots of positive comments in the Q&A. I hope you've all enjoyed it. I most certainly did. I think a big applause in particular for Richelle for her amazing introduction and high quality answers. I felt like the optimal sidekick to chime in here and there, but she really stole the show today, to my mind. So applause for Richelle. Thanks for Parkinson's Academy for organizing this. Just so you know, Parkinson's Academy and Parkinson's UK are doing amazing work for people with Parkinson's, not just in the UK, but also beyond. Please support them in their efforts. I'm a great fan of what they're doing. And I hope to see you soon on the next webinar on the topic of your choice. If you see what you like, reach out to Daiga, and who knows, she might persuade me to come back for another one next time. And I hope that I can have Richelle by my side one more time. So thanks all. And
there's more to come on diet.
all right. Bye-bye now.
Bye, everybody.